let's go now to some of the questions that have come in, and we'll do our best to answer them. I think the first one, and it's probably a great place to start, and we'll probably end on that too, is are patients really cured by this? Wally?
So chemoradiation cures people. We've often used the 5-year survival benchmark as an important benchmark, and we're now seeing over 20% of these selected patients who are alive at 5 years. Some of them will be cured, and cure is a tough word, but if you're without evidence of progression, disease, and living a good life after 5 years, I'm happy the therapy's done its job.
Yeah, and I think for the record, I trust the data will bear this out, that there are very few, I know the surgical data better than the chemo rads, but there are very few recurrences after the 3rd year, frankly.
Yeah.
And the other thing to please remember now that we have these long survivors, they're also at risk for second primary lung cancers.
Correct.
So that tumor nodule that pops up 5 years afterward under surveillance, it's more likely to be another primary lung cancer that needs another primary therapy approach.
Yep.
Jyoti, as the medical oncologist, is there a role for bevacizumab in patients receiving radiation?
So it's been a checkered past, certainly. There were initially some studies looking at radiation to sort of palliate local symptoms, normalize blood supply, and give bevacizumab to patients with squamous cancer. That failed with a high degree of pulmonary hemorrhage. In patients who were getting chemoradiation and non-squamous, there were higher rates of T fistulas and, again, more toxicity. So at this juncture, I think most of us have abandoned any idea of bringing bevacizumab into the chemoradiation space. But we are also now looking at checkpoint inhibitors with anti-VEGF, and so it may be that out back there may be a role, and that may be investigated in the future.
And what about ramucirumab?
And certainly ramucirumab has efficacy with these checkpoint inhibitors, ramucirumab with radiation, I would be pretty nervous about, and I think it's the same ideas that we're seeing higher rates of fistula formation and esophagitis.
Is that across all cancers or in lung particular?
In lung particularly, I don't know about esophageal.
I don't know data elsewhere with ramucirumab.
Yeah.
Bevacizumab issues were across many disease sites and types of cancer.
Mm-hmm. Yeah, and I think the data too was that I think people thought that if you gave some radiation, then it would be safe to give bevacizumab, and that really didn't pan out in the few trials that were done. Mm-hmm. Just a very practical question: do you ask for, as you would in a stage 4 patient, upfront, complete genotyping on a multiplex panel? Do you ask for that in a stage 3B patient that is inoperable and unresectable?
So I think it's an institutional practice. So certainly at my institution, we do reflex testing in all patients who are diagnosed as part of an institutional research effort. And practically speaking, for patients with potentially curative therapy, from stage 1 to stage 3, it should not influence your decision making. And so sometimes you may get it early on as part of the diagnostic workup, but then lo and behold, the PET looks better than you thought, or the axillary lymph node ends up being reactive and benign, and so you may have that information. At this juncture, I don't think we know how tumor mutation burden, for example, fits into these patients. Are there patients that will benefit more with checkpoint inhibitors after radiation? I don't know. So at this juncture, probably not. It doesn't fit into my treatment paradigm.
And if a patient was referred to you from another institution and then they did not have adequate tissue for multiplex testing, would you do a rebiopsy at this point?
No, not if I was planning to treat them with curative intent.
Wally, what's the paradigm at Emory?
It's similar. We don't do we do a 20 gene panel on all patients regardless of stage, and we have that as a reference. What I can tell you is it's been challenging to do trials even on a national basis that involve any kind of molecular testing for stage 3 patients. Energy and Alliance came together to do a randomized phase 2 trial looking only at those with EGFR or ALK mutations, looking at an ALK inhibitor or an EGFR inhibitor in addition to chemoradiation. And we did not complete enrollment, and the main reason was that the lack of testing of those patients at the institution, number one, or the perception that there are fewer mutated patients in the stage 3 than the stage 4 cohort. And I think it's actually a combination of both. And we're seeing that in the Alchemist trial with the ALK mutation.
It's tough because all we do is spend all day telling people to get mutation testing, know
Right.
before you treat,
Yeah.
and then in this setting that's 3B as close as you can get, we're backing away from it. So
Well,
it's tough.
I have to say, Wally, I share your experience there. I think perhaps the only time in my medical career that I had to send back a grant was a grant to give afatinib with concurrent chemotherapy and radiation that we had. That said, though, this paradigm is changing quickly.
Yeah, I agree.
Because more and more people, as part of the initial biopsy, are getting a next-gen panel, as I think all the panelists are doing at their institutions. But B, blood-based testing has changed that as well. So I think if you wanted to do that trial now,
Yeah.
and you had blood-based testing, you could.
I agree.
The other thing to people that would like to do this, and we really didn't have it at the time, is our pathologists routinely do immunohistochemical studies for EGFR, L858R, and ALK. Every time they get a diagnosis of lung cancer handed to them, it's reflexively reported and PD-L1.
Right.
So within 48 hours, we have that data, and we could refer somebody for that kind
Yeah.
of a trial.
Great.
Hey, what about giving a immune checkpoint blocker with SBRT today?
So SBRT stands for the stereotactic radiation. The answer is being done as part of trials at several centers, including our own, and proceed with caution outside a trial. There are people with metastatic disease, be it melanoma, lung or other diseases, where they are going to be on a checkpoint inhibitor and they are going to need SBRT. I like to be careful, but based on what I've seen clinically and what I've read, I have not seen undue toxicity, and there is the opportunity for synergism.
Can I ask you to make a comment on that report in JAM Oncology about the increased risk of radionecrosis in people getting SBRT for CNS lesions?
Yeah, that's interesting. We haven't seen that, but it's something we need to watch for. The reality is radiation necrosis inside a lesion is really what you're after with stereotactic radiation. What you don't want is necrosis outside the lesion. What you're probably learning in that is the kind of doses we give with brain radiosurgery, and a patient who has immune checkpoint inhibitor response is probably more therapy than they need to kill the lesion. So we have to kind of back down on something.
Another piece that I think is interesting of using SBRT in patients with metastatic disease and immunotherapy.
Right.
Often SBRT is utilized for patients with oligometastatic
Correct.
disease. And and those patients seem to have a higher PD-L1 and may be analogous to those early stage patients that you're talking about. That may be
Right.
something
Correct.
that the immune system is doing to keep the cancer in check. So.
Yeah.
Clinically, they've seemed to have a higher response. Again,
Yeah.
proceed with caution in non-clinical trials, but
Yes.
there may be something there.
I
Yeah,
agree.
one critique I had of that paper is they focused on radionecrosis, but they didn't talk about the long-term outcome of those
No,
patients.
which could have
And
been
again,
great.
But we're talking about, and perhaps when, again, these solid tumor metastases, these patients can sometimes be cured.
There's your use of bevacizumab.
And that's my use of bevacizumab, and I'd be very, very careful with that. A question came in, Jyoti, let me ask you, what do you do with a patient who progresses while they're on the durvalumab? Who develops, let's say it's a new liver metastasis, let's make it.
So I think this would be
clear-cut.
back to the drawing board. It would be, again, going back to what we know, a biopsy of that lesion. If that tumor was high PD-L1, I would treat that patient with chemotherapy.
But what about while they're on
So on durvalumab, I would rebiopsy if there was evidence of progression. And probably, again, reflexively, we would get the PD-L1 at our institution, but if they progressed on durvalumab, I would go to chemotherapy or a clinical trial.
And what about after?
Right, so the duration of 12 months, I don't know how long is the right amount.
Well, let me pick a number. A year after stopping the durvalumab, then you have the liver metastasis.
Then I would rebiopsy, and if high PDL, absolutely treat with
And if low, so you treat them like a newly diagnosed stage 4
like
patient.
de novo.
Yeah.
Exactly.
I think that makes some sense. I think most people.
But if they
would do that.
progress 2 months after stopping, would I restart? Probably.
Okay. All right. So again, and another question that came up about what is your routine for rescanning these patients? So your patient completes chemo RT. How quickly after the end of the completion of chemotherapy and radiation do you normally rescan?
My practice
In the
is,
absence of symptoms.
yeah, my practice would be 6 to 8 weeks after chemo radiation. That gives me, in what I view as the best window to look at imaging response to the chemo radiation. It's given time to respond, and it's before we start seeing some significant scarring in the radiation field.
Okay, Josie, what about you?
I don't think that we really have good guidance. It tends to be sort of institutionally directed. Traditionally, I've looked between 4 and 6 weeks, and that will likely change as more and more patients are treated on Durva. But again, this is where that clinical hat really comes into play, that you have to be comfortable that your patients have recovered from all toxicity before you initiate therapy, and then really be tuned in with your advanced care providers, with your nurses, with your entire clinical staff when you're treating these patients every 2 weeks for a year, that you're doing thorough review of systems, looking for the weird toxicities that can happen.
Yes, so our institution generally does not do another imaging study in the absence of the durvalumab for usually 3 to 4 months after the conclusion of radiation. I think in an asymptomatic patient, that is largely to get away from the process of recovery, I'll call it, that scarring that follows, and not to get confused by that. And somebody, again, who is fit, obviously if somebody is unwell, then you would need to consider doing an imaging study much sooner. We've had a lot of new issues to deal with, but I hope everybody will agree that they've been the kind of things we want to deal with. We trying to find a way to deliver an important therapy to more patients. And again, the estimation is we're talking almost 50,000 people a year in the United States that could benefit from this therapy. So it's just a great opportunity for thoracic surgeons, medical oncologists, radiation oncologists to really make a huge difference here. And this is, as much as we're very proud of what's happened in people with more advanced disease, and we've led to a lot of longer and better lives, this is a step even beyond that, longer, better, and maybe even cured. It's just amazing to me now that I've cared for people long enough that they got second primary cancers, and then I've got a chance to cure them again, things that I never thought would have been possible. So this has been a great discussion. Thank you. I thank you also for your candor and your experience, and I think folks really want to know what you do, and you were very, very clear about that. We hope that you've all found this information valuable to you and valuable to the care of your patients, and that hopefully at least some of it you'll be able to put into practice later this week. Thank you for watching OncLive News Network.